Hello friends, let us start with a prayer. The topic which we are going to discuss today academically is currently very much in discussion because there are so many public platforms where this is being discussed, and understandably, therefore, it has generated a keen interest. People are interested in knowing more about it, and not only that, it also generates some amount of fear because PCOS, polycystic ovarian syndrome, that we are going to discuss its perspective in light of endometrial cancer, PCOS is becoming more and more diagnosed and read about. Therefore, I get this question many times as a teacher and also in my clinical practice that, sir, PCOS related endometrial cancer, can we prevent it? A shortest answer possibly is, to a significant extent, yes. Now let us see some data. Women with polycystic ovarian syndrome have a nearly threefold increase risk for developing endometrial cancer. So therefore, you would like to know then, what can we do for prevention? If you want to prevent something, you have to first identify its risk factors. And let us see the most consistent clinical risk factors associated with PCOS and uterine cancer. Understandably, women between 50 and 70 years of age, women who are overweight or obese, women who begin menstruating early, say before the age of 12, and go on menstruating even after the average age of menopause, that is beyond 50. Women who have unopposed estrogen hormone therapy and medications such as tamoxifen can also increase the risk of endometrial cancer. Also, because this video is for students and practitioners alike, women who have a complex atypical hyperplasia in their endometrium have a higher risk of developing endometrial cancer. There are certain other non-OBGYN risk factors, say like diabetes, hypertension, and interestingly, women who have had colonic cancer before the age of 50. Friends, but I would like to allay your fears. I understand your fears, but one point I would like to assure you that current data clearly suggests that women of all ages with PCOS, though are at an increased risk of endometrial cancer, but the risk of ovarian and breast cancer is not significantly increased. We are asked this question many a times, and this is a clear answer. Now the question is how to reduce the risk. We've identified the risk factor. Now how to reduce the risk? The answer is get your PCOS treated. While you cannot prevent PCOS, it runs down in you from the family. It's important to know that your risk of endometrial cancer, and once you are aware of it, figure out what you can do to protect yourself to reduce the risk. And a very important point is get your PCOS treated and handled well. Reach and maintain a healthy body weight. Avoid fats in diet. And regularly, as soon as you reach that age, perimenopausal, get pap smears and pelvic examinations done regularly. Having PCOS doesn't mean that you are for sure fated to develop endometrial cancer. No, it only means, understand this perspective, it only means that you are at an increased risk of this disease compared to women without PCOS. Now, a question which I am asked many times is, can genetics help in predicting endometrial cancer as it helps in predicting this PCOS? The answer is a clear no. This study, not a very old study, just 3-4 years before, has shown that genetically predicted PCOS might not be associated with the risk of endometrial cancer. Let us identify the triggers then. First, clinical triggers for endometrial cancer. Endometrial cancer, as we know, starts in the lining of the uterus, what we call as the endometrium. So, the triggers are being overweight or obese greatly increases the risk. Other risk factors include age, diagnosis of polycystic ovarian syndrome, and a prior use of breast cancer treatment drug tamoxifen. We have identified these already in the risk factors. There are certain cellular triggers also, and that is where I am asked, as this is a lecture for students and academicians alike, sir, is mitochondria holding the key to triggering of carcinoma endometrium in PCOS? The answer is yes, indeed. It has been found that mitochondria plays a key role in energy production, and mitochondrial dysfunction at cellular level can disturb the systemic metabolic balance, ultimately triggering endometrial cancer. Now we come to the markers before actually cancer has developed, because the topic is on how to prevent or reduce the risk. And there, a very big marker, reliable marker, is endometrial thickness measure. The doctor can identify tumors by looking merely at the sonogram. And therefore, then the question is, at what thickness does the endometrium indicate a cancer alert in premenopausal or perimenopausal and menopausal women with history of PCOS? The answer is clear. In menstrual phase of a woman who is menstruating naturally, if TVS shows the thickness of more than or equal to 20 mm, this is highly suggestive of a risk of malignancy. If it is less than 4 mm, it is supportive of benign cause in both perimenopausal as well as postmenopausal women. However, in postmenopausal women, in a transvaginal ultrasound, if it is showing more than 10 mm of endometrial thickness, malignancy needs to be ruled out. Are there any other causes of increased endometrial thickness? Yes, there are. Obesity, tamoxifen use, hormone replacement therapy, diabetes, endometrial hyperplasia, endometrial polyps, and chronic blood pressure, high blood pressure, have been recommended by the Radiological Societies of North America, RSNA, to be the most common cause they have seen of endometrial thickness. In subjects with increased endometrial thickness but not malignancy, what are the treatment choices? A couple of weeks back, a couple who was regularly coming to us for follow-up, and the lady every year underwent a transvaginal sonogram. It increased from 3 mm to 4 mm over a period of years, 6 mm, 8 mm, and last time when she came, it crossed 10 mm. She is menopausal. Then they naturally would start discussing the treatment options. And the answer is very clear. The people who pay the proper attention towards the thickness of endometrium can easily optimize the way of curing it on time. The most important weapon for us is progesterone. I'm coming to that in a short time. Hysterectomy, of course, is understandable. Combination OC pills, vaginal cream of progesterone, and intrauterine progesterone devices, what we call as levonorgestrel IUDs, LNG IUD systems. Very commonly asked by patients who are not doctors, what foods reduce endometrial thickness? And they have been identified through fibrous foods, such as fruits, vegetables, legumes, and whole grain. Iron-rich foods like green, dark, leafy vegetables, broccoli, beans, etc. And foods rich in essential fatty acids, like salmon, sardines amongst the non-vegetarian, and amongst the vegetarian, walnuts, chia, and flax seeds. These are reducing the endometrial thickness. Now let us come to reducing the risk of actual endometrial cancer. And that is where the question which we would like to stress, answer of which is lifestyle change. Does lifestyle change really have much effect on prevention of endometrial cancer associated with PCOS? The answer is like this: yes, yes, unambiguously yes. A huge database of 15 studies have shown that lifestyle intervention improves the free androgen index, reduces weight and BMI in women with PCOS, understandably thereby reducing the role of CA endometrium. What about progesterones? How good are progesterones in preventing? All women who use LNG-IUS receive and followed up. They achieved a regression consistently of atypical hyperplasia. When assessed in population of women with any type of endometrial hyperplasia, there was no clear evidence of a difference between LNG-IUS and oral progesterones. Both are effective. Recent articles from throughout the world have also indicated a good efficiency of a ciproterone 2 mg plus ethinyl estradiol in reversing carcinoma changes in subjects with PCOS. These results and results of previous clinical evidence support therefore the use of combination therapy for patients with PCOS and early endometrial cancer. However, progesterone remains our very good friend. One more. How good is metformin? Because we know that insulin sensitivity and its disturbance is a hallmark of PCOS and its subsequent complications. This study has shown that metformin might directly reverse impaired glycosylations and thereby normalize mitochondrial function. And we know that mitochondrial function gets surely affected in PCOS and endometrial cancer, and therefore in these subjects with endometrial hyperplasia, metformin has a direct reversing impact. Also, considering the evidence supporting the higher risk of gynecological cancer in PCOS women, insulin sensitizer, metformin, are potential tool for chemo prevention. Bariatric surgery, with this also we are asked. Bariatric surgery is the in thing these days in the management of obese PCOS. The question which you would naturally like to know, answer of which is, does it help in prevention of endometrial cancer associated with PCOS? 2022 study. Bariatric surgery has shown its efficacy in severely obese PCOS patients surely. But a careful evaluation of benefit-risk ratio is warranted, and large-scale randomized controlled clinical trials should address these possibilities of whether bariatric surgery also helps in preventing or reducing the risk of endometrial cancer. So the final word is, the jury is out on this. Wait. What kills endometrial cancer? Meaning, what are the basic principles of treatment? The treatment of endometrial cancer is usually with surgery to remove the uterus, fallopian tubes, and ovaries. Another option is radiation therapy. Drug treatments for endometrial cancer include chemotherapy with powerful drugs and hormone therapy to block hormones, blocks it, and for which we rely a lot on. These are cases where endometrial cancer has already occurred. We have already discussed the earlier stages for prevention, for the risk reduction and all. These are cases where it has already occurred. So naturally, you would like to know how survivable is endometrial cancer. The 5-year survival rate of uterine cancer in the United States is 81%. Also, Black women are more likely to be diagnosed with more aggressive endometrial cancers and have lower survival rates. This is 2022 study. One special situation I would like to discuss, and that is, if a couple is desirous of fertility preservation and had developed endometrial cancer, how to manage? This is a tough one. Management of endometrial cancer in young women who desire to maintain fertility presents a unique problem, understandably, since the standard surgical treatment is based on hysterectomy and salpingo-oophorectomy. We are asked what to do. A fertility preserving approach can be considered only in selected cases with early stage and a low grade endometrial cancer. It solves the question. So friends, now let me put all of this in a nutshell. Q&A format. What is the link between chronic anovulation in PCOS and the risk of developing endometrial hyperplasia or cancer? This can be a revision, therefore I said in a nutshell. And I got these questions by email from different sources, and I have collated them and brought them here to answer. Chronic anovulation in PCOS, where ovulation doesn't occur regularly, leads to prolonged exposure of the uterine lining to estrogen without the balancing effect of progesterone. And therefore, this can result in endometrial hyperplasia and overgrowth of the endometrial tissue and the increase in risk of developing endometrial cancer. Next question. Are there specific lifestyle or medical interventions that have proven effective in reducing endometrial cancer risk in women with PCOS? Though it may sound repetitive, it is worth it because I am summarizing the whole thing. Yes, several lifestyle and medical interventions have shown promise in reducing endometrial cancer risk in women with PCOS. These include weight loss, thorough diet, exercises, hormonal contraceptives, combination estrogen-progesterone pills, and potentially metformin use. The next question, to summarize, how early should a gynecologist start screening or monitoring the endometrium in women diagnosed with PCOS, especially those with irregular cycles? This is a very common question. Sir, we know these are subjects who have been with us. We treated their infertility. We conducted their deliveries. They are now going towards 40, 50. When should we start screening them? There is no universally agreed upon age to start screening. It is generally recommended to initiate monitoring if a woman with PCOS has not had a period for a prolonged period, several months, or if they have a history of very infrequent periods. Also, the goal is to detect and manage any potential endometrial hyperplasia. And I've told you what we call as abnormal thickening of the uterine lining. More than or equal to 20 mm in women menstruating and more than or equal to 10 mm in those who are not menstruating, means menopause. Or other changes that can occur due to hormonal imbalances associated with PCOS. A final summary question. Can oral contraceptives or progesterone therapy help in preventing this? If yes, what are the recommended protocols? Regular gynec checkup and monitoring are very crucial to detect any signs of developing endometrial hyperplasia and cancer. The best approach, rather than giving a general protocol, is to individualize the case for cancer prevention in PCOS. As individualized based specific factors based on preferences and response to the treatment will change the protocol. Are there any red flags? The red flags include prolonged or infrequent periods. Friends, if you are a clinician, please, infrequent periods in subjects with PCOS, particularly if they are associated with obesity and or insulin resistance, is a red flag. Additionally, an abnormally thickened endometrium on ultrasound should prompt further investigation. Please encourage the patient to remain in your continuous follow-up. So friends, it was really a difficult topic. because PCOS has been discussed a lot. Its effects are not discussed much. And this is quite complex. Monitoring, risk factors, and picking up even before cancer develops. And then once cancer, what should we do? Difficult topic, but was surely exciting also. I feel that if you are alert of what is happening inside at the endometrium, and you are also alert of how these changes take place by continuously reading and remaining in touch with latest developments, then you will be in command of what is happening. For that, you will have to be continuously keeping yourself informed and well read. Well informed, well read, and clinically correlated with alertness about any developing danger signs will easily make endometrial cancer very much preventable, if not very nicely manageable at early stages. And for that, obviously, we require a scientific excellence, always at the service of humanity and mankind. Thank you, ladies and gentlemen. Thank you very much.